Now we're going to be talking about bronchiolitis. And bronchiolitis is inflammation of the bronchioles. It is a significant cause of hospitalization in infants younger than 1 year of age. And RSV, which is your respiratory syncytial virus, is the causative agent in more than half of those cases. Acute viral infection. This acute viral infection occurs primarily in the winter and spring. Transmission is predominantly through inadequate hand washing, and infants younger than 2 months are routinely hospitalized for this. Pathophysiology, it's an upper respiratory infection, RSV, and you'll see edema, mucus, and cellular debris obstruction in the bronchioles. The bronchioles constrict during expiration, and it causes hyperventilation of the lungs. So you may have atelectasis when obstruction is complete and that trapped air is absorbed. You'll have impaired gas exchange as well as hypoxia. Under clinical manifestations, you usually have that mild upper respiratory infection that usually precedes the development of bronchiolitis. You'll have a serous nasal discharge or drainage, sneezing, low-grade fever, anorexia are usually present for several days, followed by the onset of acute respiratory distress manifested by the following signs and symptoms, which is the tachypnea, respiratory rates of like 60 to 80 breaths per minute, tachycardia, heart rate more than 140 beats per minute, wheezing, crackles or rhonchi, intercostal and subcostal retractions with or without nasal flaring, and cyanosis. Feeding can be difficult because of increased respirations, which will interfere with sucking and swallowing, and the body temperature can vary from a hypothermic to a very high fever. Diagnostic evaluation, really the clinical presentation and the age of the child really suggests the diagnosis, but we'll do chest x-rays, and if performed, it's going to show that hyperventilation of the lungs and that increased anterior-posterior chest diameter on those lateral views. There usually are scattered areas of consolidation in some infants, and that's a finding that's attributed to atelectasis caused by obstruction or inflammation of the alveoli. Some infants, the chest x-ray can appear normal. If based on clinical signs and symptoms and epidemiological factors, the diagnosis is definitely determined through a rapid virus identification, and they usually get that through nasal or nasopharyngeal washings, or they may order a nasal culture, and so they can get it through there as well. This just shows you a clinical pathway for one of the institutions that they have. It's almost like a care plan that they have for a child with bronchiolitis. So in treatment, most of the infants with mild bronchiolitis can be treated at home with fluids, humidification, and rest. Infants with respiratory distress, of course, are hospitalized for supportive treatment. Use cool humidified O2 is usually delivered if the O2 sat is less than 90 on room air to relieve that dyspnea, that hypoxemia, and insensible water loss from tachypnea. We'll also do IV fluids, especially for the child that's acutely ill, who's dehydrated, or who has poor fluid intake. The infant is usually positioned at 30 to 45 degree angle. Antibiotics are usually not given because unless there is a secondary bacterial infection. They can give ribavirin for severe cases of RSV, and there is also a respiratory syncytial virus prevention, RSV immunoglobulin that they give children. On assessment, our nursing care, The nurse has to assess the infant for signs and symptoms of respiratory distress, tachypnea, dyspnea, any retraction, cyanosis, nasal flaring, at least every 1 to 2 hours during the acute phase. Very important. Auscultate the lungs for breath sounds. The baby may be on an apnea monitor. Cardiorespiratory monitoring is indicated for those with acute disease. So we want to also assess the patient, the little one, for dehydration, dry mucous membranes, decreased urine output, sunken fontanelles, and check for weight loss, and monitor body temperature. These type of children, if they should be placed in a room near the nurse's station for easy observation. Our nursing diagnosis and planning, one will be impaired gas exchange related to airway edema and increased mucus. So we want to make sure that our infant will have an adequate gas exchange above 95% on room air, ineffective airway clearance related to increased secretions. So we want to make sure that the infant will exhibit breath sounds and normal respiratory rate, depth, and rhythm. Deficient fluid volume related to decreased intake and sensible losses. So we want to maintain hydration in our infant. And we want to also maintain their body temperature within normal limits. So our interventions, we want to facilitate gas exchange. We want to document the vital signs and respiratory rate every 1 to 2 hours or more if needed. Close monitoring of the cardiorespiratory system. Oxygen administration is indicated for infants who are hypoxic. Usually the administered humidified oxygen it's usually about 35 to 40% concentration, and it depends on how old the infant is, but you can do mask, hood, or nasal prongs to decrease hypoxia and the bronchial edema. Make sure that you position, as we said before, 30 to 45 degree upright. We have to schedule periods of uninterrupted rest between care episodes, and that's important to decrease oxygen demand. We have to prevent transmission of RSV, so we isolate the infant with RSV in a single room or place the infant in a room with other RSV-infected infants. Meticulous hand hygiene is very, very important. Nursing care for the infant should not, nurses caring for those types of infants should not care for any other high-risk children because of the transmission. So we have to maintain contact precautions. Wearing a gown and glove usually is what the type of precautions you'll need, and that will reduce that nosocomial transmission of RSV. We have to maintain fluids, whether it's PO or IV. The patient needs to be on I&O. If the infant's nasal passages are blocked with mucus, we'll have to instill saline nose drops, followed by a gentle suction with a bulb syringe before they eat. We have to reduce fever in these little ones if they are having a temperature, and we'll take the temperature every 2 to 4 hours. We will give acetaminophen or ibuprofen. Decrease anxiety, so we also want to encourage the parent to stay with the child when possible. And on evaluation, we really want to ask ourselves the following questions. We want to make sure that the infant demonstrates adequate oxygenation. We want to make sure that the infant has moist mucous membranes, good skin color, and turgor, stable weight, a flat fontanelle, and a urine output of at least 2 to 3 mLs per kilo per hour. We want to make sure that the body temperature is within normal limits, and we want to look at look and see if the baby has been crying, irritable, or has increased restfulness. And we want to make sure that the parents verbalize understanding of the disease and have a relaxed appearance and demonstrate comforting behaviors toward their infant. Okay, now we're going to be talking about croup, which is a general term that's applied to a broad classification of upper airway illnesses that result from swelling of the epiglottis and the larynx. It's a group of conditions that's characterized by that inspiratory stridor, harsh, brassy, or croupy type cough, hoarseness, and varying degrees of respiratory distress. Most of the time, it's caused by parainfluenza viruses, and the types of croup include the laryngotracheal bronchitis, acute spasmodic, and bacterial tracheitis. The one that we're going to talk about that's the most common is the laryngotracheal bronchitis. The next slide gives you a picture of the pathophysiology of croup, how the mucus becomes inflamed, mucosal inflammation of the larynx and the epiglottis, and there's edema that narrows the airway. So there's that sudden onset of harsh metallic type cough, inspiratory stridor, hoarseness. They're in respiratory distress, which can lead to substernal or suprasternal retractions, agitation, pallor, cyanosis, which then leads to the different symptoms of increased heart rate, extreme restlessness, and then that leads to hypoxia. So this gives you a good picture of how the normal airway, the normal larynx is, and the trachea compared to the child that has croup. I don't want you to pay attention to the epiglottitis at this time. We're going to do epiglottitis in the spring, but know that croup often begins at night and may be preceded by several days of symptoms of upper respiratory tract infection. The child that has laryngotracheal bronchitis may have a gradual onset and a fever along with other signs and symptoms. And occasionally that fever can go as high as 104 degrees. So we can have that use of accessory muscles, frightened appearance, agitation, and that cyanosis that you'll see. On diagnostic evaluation, it's basically observation of any kind of clinical symptoms. They do have some physicians may use a croup score as they look at the child, and also look at the oxygenation status. On therapeutic management, the goal is to maintain a patent airway. Children with the acute type of spasmodic croup can usually be cared for at home. The ones that have laryngotracheal bronchitis are usually, because this is usually a more severe type of croup, are often hospitalized than those with the other type of croup. Racemic epinephrine nebulized with O2 may be given to decrease the laryngeal edema and the bronchial spasm. The child has to be observed very closely when they are given epinephrine, because it's very, very temporary, and they may have a rebound stridor, so they're kept in the emergency department for at least 3 hours after treatment and shouldn't be discharged if any stridor or retractions are present. We'll also use oral dexamethasone, which is the drug of choice for to decrease inflammation, and antibiotics are not indicated unless a bacterial infection is present with that. So on our nursing care, let me go over here to this side. Our nursing care of the child with croup, make sure that you do a really good history, and usually it reveals a recent upper respiratory tract infection. Assess the child for any respiratory, inspiratory stridor, barking, cough, hoarseness, increased heart rate, respiratory rate. Record any kind of signs of respiratory distress, the use of those accessory muscles, substernal, intercostal, and suprasternal retractions, any nasal flaring, restlessness, irritability, pallor, or cyanosis. Anytime that you see cyanosis, increased heart rate, respiratory rate, that extreme restlessness or evidence of fatigue or listlessness, those are all signs of hypoxia, and they should be reported to the physician immediately. So we basically, in our nursing diagnosis, ineffective airway clearance related to mucosal swelling and obstruction of the upper respiratory tract, risk for deficient fluid volume related to inadequate oral intake and tachypnea, and fear related to dyspnea and hospitalization. So we want to make sure on our interventions, we want to facilitate airway clearance. You have to monitor the child's breathing continuously for signs and symptoms of increased respiratory distress, increased respiratory rate, stridor at rest, nasal flaring, those retractions, cyanosis, change in level of consciousness, increased irritability, decreased or adventitious breath sounds. That's important. The child must be kept as quiet as possible because crying may aggravate laryngospasm and increase hypoxia. We also want to maintain fluid balance, so we have to monitor the child's hydration status with I&O. Check the mucous membranes, see if there's presence of tears, weigh the child daily on the same scale and at the same time of day. Make sure that you offer fluids, but they need to be at room temperature. And always observe to see if the patient can swallow, because tachypnea and laryngospasms often will cause dysphagia. Monitor your IV fluids in your child and monitor the child's temperature at least every 4, and give acetaminophen or ibuprofen as ordered. Make sure you decrease the fear. Make sure that you maintain a calm, restful environment. And if they're going home, they've been in the ER and they're going home, we want to provide teaching to the parent of the signs and symptoms of respiratory distress and symptoms that should prompt a call to the physician. Always make sure that you emphasize the importance of adequate hydration, nutrition. A humidified environment may also help increase the child's comfort. And just remember that cough syrups and cold medicines are usually avoided because they can dry and thicken the secretions, and we need those thinned out with the fluids that we give.